Samir?
Good morning, Tejas. How are you?
Good. I hope you all have had a good night's sleep. Huh?
Yes, absolutely. Yep.
Yeah. So, uh, welcome to Trico 2020. On behalf of Dr. Saito, Samir Pancholi, Sanjay Shah, and myself, I welcome all the international guest faculty and national guest faculty as well as participants who have come all the way. My international friends, despite their busy schedule, they made it, and despite the scare of coronavirus, they made it. There is nothing over here, I can assure you. And there is again another surge from the participation from Bangladesh. I love that country and the people of that country, so many very good friends, and almost 75 Bangladeshi participants have also come. I extend warm welcome to all of them to this country. This is their country actually. This is a different course now. We are changing gears. The name, the brand Trico remains. It was trans-radial intervention course, and we are this year changing it to trans-catheter intervention course. And by doing that, we want to make sure that I think everybody has learnt radial, and radial is almost now in the mainstream. We think that the new generation of cardiologists needs to understand a lot about the imaging part, the complex intervention part, and the robotics, which is very new, and it is a very promising upcoming technology, as well as the structural. Next Trico will be having major stress on the structural. We will be showing a good number of tower and LA appendage occluder cases. Here we have lined up very complicated cases. All my international guests are here. The on-site moderator, Dr. Rajiv Gulati, Dr. Akasaka are here. Dr. Takwan has also come. He is also going to show live in the morning session. Dr. Saito has arrived. So we are all set. So can you describe the case history of the first case? Pradyot?
Hello. Our patient is a 58-year-old male, normotensive, non-diabetic, hyperlipidemic. He presented to us with inferior wall MI with an LVEF of 45%. Robotic PCI of RCA was done, and it was completed successfully. Now our plan is to do a LMCA bifurcation angioplasty. As you can see in this angio, there is a distal LMCA severe stenosis followed by an ostial stenosis of LAD, which is followed by a mid-segment stenosis of LAD also. So our plan is to do a LMCA bifurcation angioplasty under OCT guidance. Thank you.
As you see, we have punctured radial. We have used a slender sheath 6x7. The 7 French EBU 3.5 is already sitting in the left main, and actually there are 2 bifurcations, LAD diagonal and then left main trifurcation. So that adds to the complexity. Ejection fraction is around 40-45. So what do you think should be the strategy?
So you're going to double wire the LAD diagonal, right?
Yes.
Protect it. And are you planning on a provisional strategy for the LAD? I'm assuming you're starting with the LAD, right?
Yes.
Okay. And so what's your plan with the LAD bifurcation?
I will take 2 wires, one to LAD, one to diagonal. I will dilate diagonal, and I will accept the result, and I will definitely not stent that artery, because otherwise there is going to be too much of crowding. In this situation, if I am doing left main bifurcation, I make sure that my left main stent, the distal landing is inside the stent of LAD, so that I don't create any dissection. I am very clear about it. Rajiv, what do you think?
That seems like a very good strategy. Let me ask you, Tejas, about
Yeah.
your
Appel
OCT
acha,
guidance plan here. Are you going to do a baseline OCT to help you guide your device choice, or
It's a
just
great
post-procedure?
question. I think I will perform the procedure and then I will take different runs of OCT and I am going to use bifurcation software. I learnt it from Dr. Akasaka, who is here. So we are going to have lot of insight about it and everybody will see such a beautiful software it is, and it helps in improving the result and creating less complexity and creating, and reducing the number of complications happening later after left main bifurcation, stenting.
Can you do OCT through the robot?
There is an auxiliary track, but you know what happens is the OCT catheter is a very soft catheter, and a robotic drive, it creates dents on it. So I push, I can do it manually. Otherwise, because it's a very, very thin catheter. So doing it completely through robo, I have my reservation.
Tejas, just for the audience here, are you a 6 French sheath
Epic,
for this case, or 7 French?
6 to 7, yeah.
6 to 7. So the
Now go to LAO caudal. Scout.
Dr. Patel, I am Professor Mir Jamal from Dhaka, Bangladesh.
It's a lot of angle there. Go to epicranial.
Hello,
Yeah.
Are you hearing
How
us?
are you? How are you?
we are fine. I am Professor Mir Jamal from Dhaka, Bangladesh. And
Yeah,
you
tell
are
me.
in distal radial approach.
No, this was a regular radial approach
Radial.
because, see, yeah, it's a good question. Why have we
Why
not
not?
used distal radial in this case?
Yes.
Because distal radial is not good for every case. Why? And what is our, strategy? Only if we palpate distal radial very clearly, then only we puncture. If we feel that distal radial is a little bit feeble, we don't puncture. We are very clear about it.
And previously, PCI was done by distal radial approach for this same patient.
No, I think that's probably that may be the reason that at the moment Sanjay examined and he felt that it is not very well palpable. It is palpable, but much feeble, so we are not touching it.
So Tejas, let me ask you, when you do an OCT with bifurcation software, do you feel that it really does change your strategy?
Absolutely. That is what we learned, from Dr. Akasaka, that we try to make sure that our wire goes to the distal most strut. Otherwise, despite giving a great angiographic picture, you are still giving an incomplete, suboptimal result, and lot of struts are hanging in the lumen at the origin, Scout.
I think I can speak for everyone that we're very much looking forward to Dr. Akasaka's input. I think there's probably no one in the world who's done more important research and
Absolutely.
education in OCT, and it's great to have him here for educational purposes.
Thank you very-
Ray balloon 2x10.
Okay, thank you very much. I'm very happy Dr. Patel decided to use an OCT almost.
Now we are
Yeah,
doing 60% of the
right,
cases
a
OCT
great
guided.
number, right? And
first diagonal.
especially, I think OCT should be used in case with the bifurcation and also the severe calcified lesion. It's quite useful in case with the bifurcation, we can identify the wire position very well and try to select the distal cell. It makes a very wonderful result. He will show in this case. I'm very exciting.
આ diagonal છે મારા હાથમાં છે નીચેનો LED છે.
Okay. This is a Ray balloon, a new balloon from Terumo, and they claim that it is even better than Tazuna. So we are trying that. Yeah, good.
Okay.
What is your experience, Dr. Akasaka, about this balloon? 6?
It's a very wonderful balloon,
Keep it for a
quite
long time.
easy to pass through the very tight region. Yeah.
Samir, now I am becoming an interventional cardiologist of 90s, you know. I am going to give 1 full minute low pressure dilatation, make it on 4, in this region.
That's true. Balloon angioplasty only, right?
Yes,
No,
yeah. And low pressure, open up, keep it on a suboptimal pressure at around 4. Keep it for a little long time, and most of the time the artery gives a good lumen. And angioplasty result I accept when I see a great lumen with a TIMI grade 3 flow and a very little haziness or dissection. So if they heal very well and they flow for very, very long time.
And Tejas, drug-coated balloon in your side branch strategy with any comments on that?
Drug-coated balloon, unfortunately, Rajiv, we don't have. But yeah, it can be a good strategy. And I want to know from the panel what is their experience about drug-coated balloon.
So we don't have it for the coronary. It is available for peripheral. Mauricio, do you have any experience with coronary?
No, we don't have experience with coronary drug-eluting balloons. It's not a technology approved in the U.S. yet.
In Japan, we do have paclitaxel coated balloon. So in case with the diameter less than 2.25, sometimes we try to use a drug coated balloon.
Are you guys able to hear clearly Rajiv and Dr. Akasaka?
Yes, we can.
Yes, we can.
Yeah. So, but my point is, what do you think about paclitaxel? Because there was some controversial paper also in between the report, deflate, that in peripheral also they have increased the complication and mortality.
But for long lesion, small vessel, long lesion, stent is not possible. In that case, I think it is preferably better.
So
AP.
Tejas, you have a residual lesion there. It's about 50 to 70% in the origin of the diagonal. So are you planning a provisional strategy, or you are planning singles?
No provisional, because there are going to be already 2 layers of this thing, because my left main stent I want to deploy in my LED stent. So even if it's not, even if I do suboptimally with that branch, I am fine. Better is enemy of good.
So one single stent strategy for that
Scout.
bifurcation.
Okay.
For the LED
You want to
diagonal.
check it? All right.
Good result.
Again, we have to dilate. LED we can do direct, I think. Huh? You want to?
Yes.
Okay. Get me a 3 millimeter balloon, maybe 3 by 12 NC emerge.
And Tejas, your experience with OCT in the left main with the bigger diameter, are you getting good pictures, good information?
70% of the left mains of Indian artery you can use OCT, because they are 4.5 or at the most 5. So I hope, I think Dr. Akasaka, do you have the same experience in Japanese artery? And in left main, when you have OCT done, and if it is a good OCT, it gives great picture.
The position of the imaging cluster is very important. We can control a little bit the pull back the wire, and then if the imaging wire is center of the left main, we can obtain a very good clear image of left main, except for orifice. Yes.
So do you sometimes modify the bend on the wire to put it perfectly in the middle? Do you have to do that?
Yes, push in the wire and imaging cluster at the same time, and then try to control the wire, pull back. Yes. And also, if we use an
sleep.
guideline, we can obtain the image of the orifice through the guideline. Yeah. So yeah.
That
yeah.
we have never done. We'll try that. Come to left
And while we're
leg.
talking on OCT, you still use contrast.
Ten,
There's some people have moved back to dextran.
Record.
You still believe contrast is the way
Yes,
forward?
it depends on how many times do you want to take an OCT, and also the depend on the kidney function, right? So if you want to reduce the
Here
total
we take
amount of contrast,
3/18.
we try to use an dextran, yes, 10% dextran lactate. Yeah. And initial image and final image sometimes use the contrast,
want
but
to put a small
if
stent and
the
then I can use
contrast
a 4
is
millimeter
within the
stent in
guiding
left
catheter,
which
we
goes
can
inside
initially
this.
check the condition by the movement of the contrast for 2 or 3 cc. And at that time, we can get an angioco-registration if you want, yes.
18. Okay. 3/18 Giants expedition. Why? I think Malcolm is on panel. Huh, Malcolm?
Good morning, Tejas.
Good morning. Any advice on this?
Well, I was going to ask before you started doing this, if you really did not want to stent the diagonal, would there be a case to be made for not pre-dilating it? Because I see that it looks as though there's a dissection there now, and maybe just to gain provisional balloon angioplasty or stent of that diagonal, because it's clear that you're reluctant to add additional metal or stent to that LAD.
Yeah.
So at least from here, it looks as though there may be a dissection there. And so one other strategy might have been to have, again, if you're reluctant to go with a two-stent strategy up front, to have maybe left that alone, and then just, if you lost flow, you could then dilate it and had a stent later. But I think it looks a bit more complicated now.
Let us see. See, I would have done LAD diagonal mini crush, but in that case, I would have taken a little longer stent of LAD. But in that case, a small stent in the left main, I don't like. I want the stent at least 15 millimeter by and large when I am doing LMCA bifurcation, because otherwise, I don't feel comfortable. This is absolutely my personal experience.
Just maybe one other question, and it really just gets back to the overall thinking before you start thinking about your PCI strategy. So I didn't see when this patient had their STEMI. That was recently?
That was a couple of months ago.
Okay. So in your practice with patients who have a STEMI and have multivessel disease, are you routinely doing staged revascularization? And if so, when do you
By
do
and
it?
large, in the same hospital stay. By and large, I will wait a day or a couple of days, but I will, by and large, avoid doing everything in one go. I want that artery to flow, and most of the time they are hypotensive. I like to keep them little hypertensive, little tachycardic, so I want the thrombus to be finished all the way, and then I want to see that artery clean before touching the other artery.
Yeah, we've taken the same approach, I think, now for a number of years, avoiding your complete revascularization at the time of the infarct. The diagonal is looking a little bit better now too, isn't it?
Little better, yeah. And the very fact that I opened up diag despite dissection, rather than a 95% diag, I straight away dilate and it occludes. It becomes extremely difficult. If at all I want to wire it again, it becomes extremely difficult. Here, from this lumen, despite dissection, by and large, I should be able to find my track. Sanjay, what do you think?
Right?
Tejas, do you think you need to post-dilate that stent in the middle?
I'll do everything once I finish my left main job. I'll do everything. And I'll take an OCT run to decide that also. Because if I see the expansion on both sides around 80% in that region, I will not even do that, because I tell you, apposition good and expansion 80% plus, on both sides. If I do a high pressure over there, there is a good chance that there will be more plaque shift, and in that case I may compromise with diagonal flow. Rajiv, what do you think?
Negative on
Yeah, I
both
mean,
sides.
I'm noting Dr. Akasaka's work, and I think that seems very reasonable. That septal's also a little bit pinched, and I think you do run the risk of side branch compromise with too aggressive post-dilation. But OCT would be
Epicaudal.
very keen to see the OCT and some measurements and discussion.
Diagonal का हो जाए. So now, this is a typical Indian strategy. I am out and I am in. Okay? Not wasting another wire. Phew. Now we want to profile left main. Sanjay, which is the best view? Epicaudal
and areocaudal.
But that's areocaudal.
And Tejas, your plan after this is to keep the patient overnight or to send home the same day?
Oh, no. I'm going to keep him, scout. No same day discharge in my place. Because then, after dilatation, the left main also looks okay, good. So 4 by 15?
4 by 15, yes.
Huh?
4 by 15.
4 by 15. See, I am not touching even the ramus. I am not wiring ramus. I'll wait. What happens is, if you crowd the coronaries with the wire, there is many times there is entangling of the wire, and that creates problem. Pushing the stent and balloon, and you remove one and you put other. So we try to make it simple. It is easier to cross it rather than to doing all those things.
So Tejas, how did you decide to put in selecting to put a wire in the circumflex versus the ramus?
Yeah, because ramus I feel will act as a buffer when we are stenting left main bifurcation.
But in this
And
case,
Pardon?
in this case, ramus looks to be smaller. That is, there is disease in the proximal ramus.
See, even if it is a bigger
This is-
ramus, I want 2 wires to be as wide apart as possible for even the better better placement of the stent and better expansion of the stent. What do you think, Rajiv?
Yeah, no, it's an interesting thought. I'm looking forward to seeing the imaging here.
Imaging will be fantastic in this case, I guarantee, because this left main will show everything.
So Tejas, you're saying so the second wire you think mechanically splays the circumflex away from the LAD? Is that
A
what you're
little
saying?
bit. Little further. Go.
Okay, see there. Yes, covers.
Looks good.
Covers, yes.
Go.
I'm going up.
Here we go on maybe 8 or 10.
8.
8.
While we're doing this, can I ask Dr. Akasaka what percentage of patients go home the same day
Record,
after PCI?
reflect.
In Japan?
No, in Japan, I think at least one night we try to keep the patient in the hospital. Yeah.
Good morning, Tejas. Why not a long stent and LMC to LED?
Yeah, that's what I told Jess. If I am using a LMCA to LED long stent, you have to do proximal optimization, and you can't use a 4 mm stent in LED.
There will be gross mismatch of dia.
So I want to make sure, and I don't want distal dissection, frankly.
Yeah. But suppose 3 mm stent can go up to 4 or 4.25.
Yeah, but still, if the artery is 4.5, you see a great amount of malapposition. This balloon is almost like a non-compliant balloon, Giant's balloon. I like that way, this balloon. And many times, we are using this for the post-dilatation.
Nice.
Look
no
here.
pinching, No pinching.
What do you think? Diagonal flows, ramus flows, circumflex flows.
Yes.
Now my question to the panel and on-site moderator is, do you want me to cross the circumflex ostium and do kissing balloon before OCT? Yes or no?
Before OCT, we do not want to recross as because there is stemi 3 flow there and there is not significant plaque shift. So before doing OCT, I do not think that it
We'll do
requires
pot, 4.5
recross of
4.5 by
the
6,
Shortest.
NC emerge 4.5 by 6. I am doing even 4.5 dilatation before doing OCT because I want a clean OCT run. Rajiv, what will you do?
I think I would pull the side branch wire and rewire before I did a post-dilation. It's one thing I would do. I personally would not, and there's a great debate whether to do routinely the side branch KBI or not. Personally, in this case, I would not. It's a very short segment carinal shift lesion appearing, maybe an IFR, FFR, but I would typically be conservative on this sort of side branch. Other comments?
Samir and Mauricio, what is your take on it?
Tejas, I think you got a very good result. There's no much plaque shift. So you can do those. My only fear is that the stents may be a little bit underexpanded. So
that we will show you on OCT.
So do OCT now or post-dilate now and don't waste it OCT later?
I am doing pot, proximal optimization beforehand, 4.5 balloon.
Yeah, I think OCT will help a lot, and then the part's a good idea before you put the catheter in.
Yeah, when you select the side branch, after pot should be better if we want to select the distal cell. So if we want to take an OCT, it might be better to do the after pot.
Okay.
And there are only one paper showing in the FFR in the crossover, after crossover, left main from Korea. Actually, the FFR is, if the FFR is more than 0.80, the result is very good. But even
record and deflate.
in case with more than 0.80, 2 years or 3 years later, there are increase of the side branch stenosis because of the strut on the side branch may make some stenosis.
Fine.
Looks good.
Good.
Any other view we want to check? Epicranial. There is not much of the plaque shifting. I expected a good amount of plaque shifting.
That's good.
But that, that is the beginner's luck, the first case luck, huh? Okay.
Fine. Super.
Looks nice.
OCT now.
Now we will do OCT.
OCT.
And we will use bifurcation software. Yes, are you ready?
Tejas, do you think that there's some mild underexpansion of the stents in the mid segments of the proximal LAD?
That is what even proximal LAD, you mean to say, left main?
In the proximal LAD.
That is what even Mauricio raised, that particular concern. In last maybe 1.5 years, we have done almost 600 OCTs, and now we can correlate our angiographic picture with OCT because going back and forth. I will show you 99% there is not going to be any underexpansion. Let us see. Dr. Akasaka, what do you think?
Yeah, you already have enough experience, more than...
No, not like you. You are the guru.
Yeah, no, but more than 600 it should be enough to understand how to use an OCT and how to read an OCT. Yes, we always think about the anatomy of the coronary artery. I think the diameter suddenly changed just after the big branch. In this case, there are two side branches, right? branch of CX and LAMS. So the size might be a little
Ready?
bit smaller. Yes.
Yes. Tell me.
फ्लोरो एक मिनट बंद कर फ्लश कर
Flush.
Tejas, is it possible for us in the audience here to see the OCT images up
Yeah,
on the
yeah.
screen?
On a big screen you will see. There is some, yeah, Gias is trying to fix that.
While we're looking at this,
What do you want?
Maurizio,
Yes.
Samir, do you guys routinely do FFR, IFR for side branch questions in the left main?
Reconnect.
Not
So we'll have to wait for a couple of minutes.
not
Pressure,
routinely,
pressure,
no.
pressure.
If I have a worrisome lesion, but I know it's not a big branch, then I would, on my way, prove it that it's an insignificant lesion.
Malcolm, any comments on that?
Yeah, so I think if there's real debate, I've certainly used it not infrequently. Typically, I'm just trying to avoid to do any intervention on the side
Yes,
branch.
OCT image is
I mean, the worst that's going to happen is the patient may come back with some restenosis, and you can deal with it then. But you know, if you can get away with one stent, I think that's preferable.
I think someone did a survey recently, and it was more than 50% of people were doing routine kissing balloons in single stent left main
want another
strategies. And to
catheter?
me, that I agree with you, Malcolm. I think it's asking for potential complications. Sam and Maurizio, do you guys do routine KBI?
Sometimes I do final kissing. No, sorry. Sometimes I do final kissing stenting, final kissing balloon just to deform the stent and change the geometry.
Change the catheter?
Trying to access
Just
from
give
the
me another
distal
catheter. There is some issue with this.
and push some struts into the surge just to keep it open. But the truth is that I don't have any real science for that.
But what we do know is that the most common side of restenosis here is once you've injured, is that osteum of the circumflex. And I mean, the worst that's going to happen is you're going to leave a person with single vessel disease, and you know you can deal with it then.
Absolutely.
I think the priority should to make sure to get the absolute optimal result in
Catheter
the
change
left
kar do.
main and that osteum of the LAD.
And you can still treat that with medical therapy.
Absolutely.
As somebody once said, the main thing is to keep the main thing the main thing.
Sorry, we will take another couple of minutes to set the things right. So we keep the discussion going, okay?
So Tejas, your anticoagulation strategy here is just heparin with an ACT guidance, or
Yeah.
just
We make sure that it is remaining around 300, you know, during the procedure. And then, in this case, I like to give heparin for next 24 hours. And he will be discharged on Brilinta and aspirin 75. And normally, Brilinta is not so well tolerated in our population. Many of them, they complain of breathlessness, dull feeling and all those. So, still, we continue it for at least 4 months. And then in this case, because it is left main, I like to put him on prasugrel aspirin combination for another 1 year, and then aspirin clopidogrel combination. I want to ask you, although the guidelines mention that after 1 year you can switch over to single antiplatelet strategy, what do you do in your practice, Rajiv?
exactly that. I think, and I love Malcolm's comment on this, but typically we would not extend the duration of antiplatelet therapy, would not use a left main as a reason to extend the duration of antiplatelet therapy.
I don't do in my practice.
But even the use of prasugrel, I mean, I'm not, is this patient an acute coronary syndrome patient?
It's post-STEMI, a couple of months.
Post-STEMI.
Yeah, so you may have a good argument there to use a more potent P2Y12 inhibitor there, like prasugrel or ticagrelor.
So maybe, I know you're trying to keep the discussion alive whilst you're getting this OCT set up, but let's just go back to the little brief discussion we had earlier about same-day dismissal. And I think that,
But so what is the problem
you
here?
can elaborate too here, of course, but in our practice for our elective PCIs, probably almost 90% of our patients who are eligible for same-day dismissal are dismissed. So it's very rare that we actually keep someone in. They would typically, if they do have to stay in overnight, it's usually someone's had a complication during the procedure or there's something unusual. But a case like this, which I anticipate is going to look like a fantastic result at the end, this is a typical patient we would send home same day. Do not keep them in hospital overnight. There are some risks with keeping patients in hospital. Hospitals are not the safest places to keep your patients.
Well, if your patient is healthy now, hospitals are for sick patients, right?
And sick patients can get sicker in hospital.
They are restarting it, unfortunately. It never happens. Huh? This has happened in last 1 year for the first time.
Let me ask you about access, Tejas. We talked a little bit about that earlier on. So this is, I'm not asking for an evidence-based question, I'm asking for your practice. So let's say this radial was occluded after his last cath. Your routine second choice is ulnar or left radial?
Never ulnar. Never ulnar. If in this case I have to puncture left radial, it has to be left distal radial. I tell you, right or left, distal radial has an advantage, and particularly in aged population. He is not all that old. We have evolved from the monkeys, and this is the normal, posture. And when during evolution we became human being, this is our natural instinct. Like prone or semi-prone. Instead, you are doing supination, and at times you are doing extreme supination, and then internal rotation like this. This is very uncomfortable for the left. And if the patient is sleeping like this is a normal, natural human instinct. So absolutely no pressure over the shoulder or elbow, particularly when patient is very old, or even otherwise for the comfort of the patient. And that holds true even for right distal radial. So whether it is right or left, it really doesn't matter. Distal radial, I think if I have to use, I will consider this thing very, very important.
That's very interesting. I'm interested in how forthright you were at saying no to the ulnar. Is that because of the theoretical concern, or you think we...
Yeah, it's a good question. I have gone through, in detail, the anatomical part and the etiology, the overall evolution of ulnar. If you see, ulnar is the continuation of brachial, and radial is an offshoot of brachial. So anything going wrong with radial, it's very forgiving. The things going wrong to ulnar may not be forgiving. And of course there is a nerve there and all those things. But the main thing is, it is continuation of brachial anatomically. And that's the reason why I try to avoid it.
Started.
Are ready?
Yes.
Thank you, yes. Dr. Akasaka, are we all set to go?
All right. Okay.
Can you guys see the OCT yet on the screen? We have
not yet.
They will show. They will show.
Yes, we can.
No. Okay.
Okay.
So Tejas, just for the audience, that end marker is just a marker. It's between the second and the third markers is where you're going to be
That's
imaging
right.
from.
That's right.
Okay. Set to go.
So the three markers, and you ignore the distal one.
Chalo.
We are not doing angio co-registration. We are straight away going ahead. Yeah. Ready? Fluoro. Inject. And we see a beautiful recording. I guarantee you.
Wait,
There is a dissection there.
small dissection.
Small
yes,
dissection.
yeah, and position in the distal portion is very wonderful, right?
Yeah.
Okay. Wait a moment, a little bit. There are
This is diagonal.
Yes. This is an auto measurement system already. Yes.
The proximal expansion we are not able to see properly because there is
some contrast here, right? So.
Bifurcation
Okay.
was
That is swirling, yeah.
Unfortunately, in the
We can
proximal-
take it back
we
and
can
take
take
another
second.
shoot
Yes,
so that
yes.
we can see proximal
Yeah.
area very well.
Right.
Another one shoot.
Yes.
But regarding distal,
Distal-
part and LAD, what is your comment, Dr.
Yes,
Akasaka?
here is the distal stent proximal site, right?
Yes.
Wait a moment. Yeah. So there are no under
Absolutely.
Yeah, right. Yeah, here might be a different one. Yes.
This, if we see expansion is
Here.
it's looking like 70% there.
Right. A little bit. Yes. Just on the side of the
Okay.
opposite side of
So
the.
you
yes, it's
you
that.
guys were right. I have to at least keep it to more than 80%. We'll
Right.
do that at
Yeah.
last. But meanwhile, let me evaluate the left main.
Dr. Akasaka, for the audience, that dissection
Okay,
at the
fine,
distal
fine.
stent edge, what features of the dissection on OCT make you
Chalo, we are
reassured?
ready.
It's an after ballooning, right? So the very small amount, less than 60 degree. And
Less
the
than 60 degree,
yeah,
yes.
length should be, I try to measure the length here to here, right?
2 millimeters more than.
This will
Around
not bother,
here, right?
absolutely.
So in the
So-
old days, we used to worry that OCT would make you do too much more, but
No,
you
no,
clearly
no.
won't stent
Yeah.
this. For the audience,
Yeah.
I'm just,
Yeah, that,
we
you
mustn't
know,
overtreat this.
from the center, the arc less than 60%, the dissection length less than 3 millimeter, and minimal stent area more than 4.5, just forget it. And of course, not going too deep in media. Fluoro?
Any comments, Dr. Akasaka, on?
Yeah, there are one recommendation consensus document. If the dissection is within intima and the degree of the dissection is less than 60 degree and the length is less than 3 millimeter, it should be okay to leave it alone, right? So there are no
This is
problem.
left main now.
Yes. Okay.
This is guide.
Do you think there is a dissection in the left main also?
That can be ignored. Absolutely.
Here is a
Absolutely
small
ignored.
dissection, right? It's small, right? So it is also the within intima and less than nearly.
And looks like it is extended to media and little hematoma also.
No.
No, here is
There
the
is no-
dissection, right?
nothing.
Yeah.
And this dissection cannot progress.
And here,
You are worried about distal or proximal dissections. I think proximal dissections, they don't progress much.
Frankly speaking,
do you think that distal dissection was induced by your balloon dilatation rather than your stenting because it is much
I
away
agree.
from
I
your-
agree. Because I use 4.5 millimeter balloon, but I wanted to use it because I wanted my studs to be buried inside in the left main. That is for sure.
okay, here is the proximal edge of the left main, right? So our position is okay, but as yes, the discussant pointed out, small dissection
Yeah.
here, but nearly maybe very small, less than 60 degree,
Yeah.
right? Maybe okay.
And where is it going to progress? It can't go anywhere.
Yes, in front there is a stent.
And those white dots, Dr. Akasaka, for the audience, this is
Yeah.
showing stent apposition?
Yes, I always put the CX in the 9 o'clock.
Rendered
Because if
stent.
you put the 9 o'clock here, the upper side is an epicardial side, the other side is myocardial side. It's quite easy to understand if there are lots of branch. If the branch comes to the upper side, it might be diagonal, and the other side, the 6 o'clock, it should be the perforator, right? So it's quite easy to understand. So here is the other branch, right? It's in the lumps, I think, right here. So a little bit hanging here, but might be okay here, right? CX is okay, but the small amount of yes, overhanging here is the lumps, right?
See, doing anything through the struts, you may unnecessarily fiddle around one branch. Yeah. So, my wisdom says that I will not touch that. Absolutely. What is the opinion from the panel? Bifurcation software laga?
Okay.
Let us use the bifurcation software.
Bifurcation, right?
Comments from the panel on their OCT usage and in this patient subset?
Here you can see here is in the left main, here is in the CX orifice, and here might be the lungs, right?
Yeah.
As we expected, small, yes, carina shift in the lungs,
Yeah.
but the main branch of the
Circumflex
CX.
has a good
Okay,
lumen,
yeah, right.
not too much of overhanging.
And
this is good.
Right, and you can identify also the link here. This is a giants, right?
Yeah.
Here is a cell, and here is a link. We can identify clearly the link as well, right?
And Dr. Akasaka,
Yes,
this is
yes.
a link-free type and L6 origin, so it should be a good thing to, even if you want to do a dilatation, this optimal.
Okay,
Yeah.
yes. Here,
But if you see that ramus branch, and that is most probably connecting to carina type,
yes,
link goes across side branch.
Yeah,
So that may not be a good thing to dilate it, but you end up with stented distortion.
Is it Vijay Kumar speaking?
Yeah.
Yeah, Vijay
Good morning,
Kumar,
sir.
how are you?
Good, sir. Good morning, sir.
Good morning.
busy, you know the very well. And here is an CX orifice, and here is a lungs.
Yeah.
And between we can identify the strut, right?
Yeah.
And here is the link.
If you could remove that wire.
Is a link.
Yeah,
So,
yeah.
so how to treat this is a big issue. We do not have enough data to show, but if we want to, select the lumps and you do the kissing, this strut goes to the mid portion of the CX.
Yes.
Still, there are some problem, right? So
Yes. I think, see, I always tell the young cardiologists who are working with me that when you see a patient overall, and you decide your strategy, you keep one thing in mind, that you are treating the patient and not treating the blocks of the patient. Same thing here. I don't treat OCT finding. I will consider OCT finding in relevance with overall, acute and long-term prognosis of this case. And I personally feel that this is an optimal result, and I will not do anything. What is the, I am removing everything, and we take a few views, and the other lab, Dr. Saito is ready with a very complex CTO. So, and all the young guys in the audience, I want you guys, to make sure that you sit during all the talks. We have, kept very, very good didactics, and Dr. Malcolm Bell's talk is very, very important for the young generation. So, and even for us. So I think we should be listening to the talk rather than, that is a time I know that many people go out for tea, coffee, but please refrain yourself, because that is going to be a very, very informative talk. After the first
Tejas,
session.
thank you so much for that. We're going to make arrangements to have the door locked.
Thank you.
And Tejas, you're still the young generation.
Patel, for doing nicely difficult case.
Thank you. So this
Beautiful
is
case.
all about it. And I am very happy with the result. Thank you very much. It's a good start, and I expect you guys to enjoy the case selection we have done, we have chosen. It's a very, very complicated cases, and we are going to show a lot of imaging, both OCT as well as high definition IVUS. And switching over to the South lab. Okay? Yeah.